you're an expert in all things cardiovascular imaging, and imaging around cardiovascular disease is not just MR, but you're also a spectral CT user. So how do you see the two technologies merging together? Let's talk about cardiomyopathy, for instance. You can use both types of tools, but maybe it's not so easy to get access to an MR. I don't know.
Yeah, it always depends on the clinical indication, for example. Yeah? So CT imaging is, for example, especially done in an acute setting. Yeah? And for example, if you think about patients who present with a troponin-positive chest pain, you can do, for example, a spectral CT to rule out like acute aortic syndrome or also coronary artery disease and also pulmonary embolism. And you can do this with spectral CT even with less contrast nowadays.
We say it's a triple rule out, but you can actually even do a quadruple rule out because you can also look at myocardium now.
Sure. With the power of spectral CT, we got this, for example, iodine maps for free, and we can look for enhancing lesions in the myocardium. And therefore it is even possible to look for differential diagnosis like myocarditis, for example, in patients with a troponin-positive chest pain, or we can also look for acute myocardial infarction in these patients, despite the coronary arteries being normal, and this is typically referred as a Minoka syndrome. Minoka
microvascular disease.
Yeah.
Yep. So, also scanning time, when we do delayed phase imaging for cardiomyopathy with MR, I'm imagining that your delayed phase might be 10 or 15 minutes, and I know it's not standardized. If we were to do the delayed phase imaging for cardiomyopathy on the CT side, how long is your delay?
So the delay, it's typically a lot shorter. So typically, if you look at papers who have been recently published, it's like 3 minutes. So you can do your arterial phase acquisition, for example, and then the patient has only wait like 3 minutes on the table to do your late iodine enhancement imaging. This is a really game changer, for example, because we, with the iodine density, we can also calculate the extracellular volume fraction. Yeah? And this is the part of the myocardium which is not taken by cells. So it is especially increased, for example, in myocardial fibrosis or also in amyloid depositions. And we know that especially if we look again at the elderly population, for example, in patients...
Contrast nephropathy, that has to be important.
We have to reduce the contrast, and with the ECV we can also look like, for example, in patients which are scheduled for TAVI planning, we can look for diseases like amyloidosis, for example.
All at the same time.
Yeah, and we know that 1 out of 8 patients has an amyloidosis, and we don't see them because we don't look for it, because we don't calculate ECV. And there's also a treatment outside nowadays, so we need to look for this in the future, I think.
We are in the radiology community, certainly in the cardiology community, but to put a number on it, you've seen some of the data that's been presented this year. I mean, people are significantly dropping the amount of contrast that they use for coronary CT down to 20 milliliters with spectral. For CTA of the entire thoracic aorta, they can do it in 15 milliliters. So we really want to make every drop count when it comes to imaging, because we want to save kidney cells. We want to save nephrons, no?
Yeah, of course. We want to save nephrons, as you already mentioned, but we also want to maybe save money. So it's also sustainable. And it's especially like in older patients, it's also good to apply less contrast because they eventually need more imaging exams, like young people. And like with this virtual monoenergetic images, we can have the signal boost we need to evaluate also arterial and venous vessels.
Philips.